people coming in, but then hopefully we can all get away and watch the evening events on the TV. Okay, so I'll hand you over to Manny. Thanks very much.
Thank you. What evening events? Am I missing anything? It's wonderful to see so many people today, considering there's a lot going on today. My name is Manny Hussain, as you can see from the presentation. I'm Director of Primary and Community Care for the CQC. For my sins, I'm the National Director, so Primary Care is under my portfolio. So I guess obviously I've had a chat with a few colleagues this evening, but just to give you a bit of background, where I started and how I ended up in the CQC. So for over 30 years, I'm a clinical pharmacist by background, and over the last 30 odd years, I've spent most of my time in primary care commissioning organisations. And actually, Leeds is my hometown, and I was working for Leeds Health Authority as a prescribing advisor in 1999. Okay, so it's good to be back. But I have been back since 1999. But so I've all my career really has been very much focused on primary care, and actually I've also done a stint in community care as well, because at one point I moved jobs and I became head of operations running community services across 2 towns. So that was a long time ago as well. So I've had a long affiliation with primary care in various roles, from Director of Medicine Optimisation to Deputy Director of Primary Care across a number of CCGs. I've held positions, leadership positions for NHS England, contributing to national strategy as such. I've got an interest in medical law, legal aspects of medical law, so I spent two and a bit years studying the legalities around prescribing and medical practice, which comes in handy, I guess, to a certain extent if you work for the CQC. So I've got very much, I am biased, I've got to be absolutely honest, I'm very much biased towards primary care and community care as part of my portfolio. I joined the CQC during COVID, it was October 2020, and I'd left my Deputy Director role, primary care role, and I had enough of commissioning, wanted to experience other things, so I went back to working in general practice, seeing patients. And like anything, you want to see patients, you want to do clinics, and then they find out your CV and they say, oh, do you mind doing this and do you mind doing that? Before you know it, you're managing projects again. But I worked for a federation for, it must have been about 4 or 5 months, because I was looking for another national role, and the CQC. I joined the CQC in October 2020 as Deputy Chief Inspector for Primary Medical Services, and that was covering the south of England. And as you know, over the last few years, there's been quite a lot of transformation in the CQC, and I've held my current position of Director of Primary Care and Community Care since April 22, I think. But when you work for the CQC, you tend to go time. I find weeks, months, even years sometimes merge into it. So thank you very much for inviting me today. I will briefly talk about a kind of strategic direction. But what I'm really interested in is very much your questions. And so I'll give a bit of a preamble of the CQC. So, a few years ago we updated our strategy, and that was after consultation and what have you. We were working in a changing environment. There's been a lot of change over the last 2-3 years, accelerated change, and we started implementing our strategic aims about 2 years ago. And what we're listing here are 4 of our major strategic aims. People and communities. So as at the CQC we realise that we need to be more accessible to people and communities, listen to their experiences. At the same time, help them understand what good looks like as well. So that is one of our main strategic aims. The second point is smarter regulation. So we were committed to become smarter in terms of our regulation, and I'll talk a bit more about that in terms of the old way of working and some of the inflexibilities and the new way of working and some of the flexibilities that offers. But smarter regulation is also about data intelligence, having better IT systems, because we were using IT systems that had been developed over many years. Often they didn't talk to each other, often you had to copy and paste, and obviously Leanne will be testament to that. So we invested a lot in a new IT system based on Dynamics 365 for those who like IT. So we want to be smarter in terms of our regulation. The fourth point is safety through learning. And one of our focus as an organisation is trying to understand the culture behind the providers that we're registering, whether it's small, whether it's large, and to understand whether there's a culture which allows learning to happen in a safe manner. It's a numbers game really. Whatever you provide in services, there will come a point where things don't go as well as you hope, but it's how an organisation reacts to that and responds to that. So that's a key element through safety through learning. And the fourth bullet point was about accelerating improvement. As I go and visit and speak to GPs like yourself, over the last many years, I've had feedback, and good feedback, to say, well, it's great for the CQC to come here, have a look at our systems, talk to our staff, patients, and then say, you're not doing this well. That's okay, that's quite good, but this is an area that you need to improve, and off you go. It'd be great if you can give us a few more pointers. You as an organisation also need to support and help accelerate improvement. Now, it's a fine balance because we're an independent regulator, and we've got to achieve a balance by which we're clearly being independent and highlighting areas of improvement and areas of good practice, etc. But we don't want to cross the line by which we end up marking our own homework, and that's a very fine line. But I've accepted that, and the organisation has accepted that as an organisation we need to do more to accelerate improvement. And I guess one of my role and others is to identify practice, visit places which are doing some innovative work, and as I'm speaking to colleagues up in NHS England and I'm meeting colleagues at conferences and what have you, share some of that work. And what I'm also encouraging our inspectors is, if you've seen something go elsewhere, point people in that direction. There's no mandation that thou shalt do this or what have you, because we don't tell you what to do. It's your practice, it's your service. You deliver the services the best, in a way that you think are best for your patients. So we're not going to dictate or tell you how to do things, but what we will do is highlight areas by which you're not fulfilling the regulations. So I think we've got a really good role to play in accelerating improvement. We've got a long way to go, but that is one of the key areas. So these are the four kind of pillars, but on top of that, there are two other golden threads which run through these strategic pillars. One is our role to evaluate systems, and this came in April. It wasn't this April, it was probably the April before. I've lost time. I told you CQC time sometimes gets me confused, but the reality is we have the power to assess systems. So for those of you who kind of interact or have roles at the ICS or ICB. We also now have a role to actually look at the system and how people across the system are working together. Because general practice, it can't work in isolation, it's part of the whole system. And pressures in the system elsewhere will have an impact on general practice. If something isn't working, if the ambulance service is queuing outside hospitals, if community provision if community provision is not there, or waiting lists are long, well, people are going to turn up to the GP. That's the portal of healthcare, and they will say, I haven't seen my consultant, I'm still waiting, my condition's got worse, I want you to help. What do? You've got to try your best. And so general practice is unique in that it is the gateway where people actually turn up when even the support that they need might lie elsewhere in the NHS. And if they can't get that, then naturally they will turn up to the GPs and expect some support. And it really does put GPs in a difficult situation. As I mentioned, I'm a clinical pharmacist, so I still do sessions in general practice. Most of mine are around hypertension, care of the elderly, and basically polypharmacy, to be honest. And I see people coming in with problems which they need some support. I had a situation where, unfortunately, a patient who was under the cardiologist was suffering some symptoms. Tried to get hold of the cardiologist, just wasn't happening. So we, myself, in line with the duty GP, had to help the patient, but the patient understood that they couldn't get to the cardiologist, but still wanted general practice to do something. So often you find yourself in difficult positions like that. So we do look at the system, because the system does have impact on all sectors, including primary care. Okay, what has changed? Now this is an old slide. I've been using this slide for well over a year. Before it was, we're going to change, and now it says we have changed. So there's three things here, new ways of organising, and Leanne maybe later can explain how she's part of a wider team now. Probably it was about 2 years ago, I think, where the integrated assessment integration teams were set up.
About 12 months ago.
12 months ago. And the reality behind that, prior to that, our primary care inspectors, our primary medical services inspectors, were part of one team. And they were part of PMS and as such, and a decision was made to take inspectors from all disciplines, whether it's hospital, mental health, primary medical services, etc., and put them together as one team. So that's happened. And the logic behind that is very simple. As the environment is becoming more integrated, then our teams naturally need to be integrated, because sharing of information, and it's what I've said about sometimes an issue in one part of the system will affect the other part of the system, so you can't really treat it in isolation. So that's happened. New responsibilities, local authority assessments, that's been going on for a while. And assessments of integrated care systems, and this is where we visit an ICB, look at how the system is working together to reduce inequalities. That's a golden thread. And those assessments are still ongoing. And then the final thing, and this is a significant change, and this was, we had a new policy. We went from multiple frameworks of assessment. So we used to have an assessment for primary medical services. We used to have an assessment framework for mental health, hospitals, community, independent health, and the list goes on, adult social care. And we were all recording things slightly differently in different ways, and a decision was made in the old strategic objective of smarter regulation that we need to have a single assessment framework which actually applies to any provider, and there will be core elements of that which apply to anybody who provides health and social care services. But of course, each sector might have nuances which might apply or might not apply. But we've implemented that, and today I'm going to just talk you through some of the framework around the single assessment framework. Okay. Right, what you see here is some of the changes that have happened over the last 2 years. So I've mentioned the single assessment framework. Previously, albeit we always receive information, we always monitor information, because at any time somebody can complain to us or we receive a piece of information which we need to act on. But our approach previously was very much we receive the information, we act on it, and then we go out, we do our assessment. If something needs improving, we highlight that, and then we would go back at a reasonable time to see if there was improvements and change the rating. And often, unless there is something quite focused, often you'd have to look at everything again to change the rating as such. And that often left people with required improvement, and they'd done all the work. And especially during COVID, I used to get emails from certain GPs saying, you know, we've done all our improvements, you visited us on such and such, we're required improvement, we've done everything, come out and re-rate us. And we just didn't have the capacity to do that because we were dealing with more concerns coming through, and that was during COVID time. And there was a bit of a balance as well of not necessarily visiting unless it was absolutely necessary and proportionate to what we needed to do. So there were some disadvantages there, that to change the rating you would have to go and do lots of things before the rating could change. Under the new methodology, the aim was that we can look at various things, and based on what we can look in, we can change the rating. Okay, so it offered us a lot more flexibility. The other thing about the new methodology is that at any time we can particularly say we're going to focus on one area, and we can just look at that area, and again that might result in a change of rating, or it might not. So it's all about flexibility and not necessarily looking at everything, but looking at parts of the quality assessment. So rather than doing an inspection visit, looking at all the evidence on one visit, we now have the ability to look at different things at different times under the new assessment. And the other thing that came out, and this came out from the strategic element of it, the previous reports are very narrative, and you can read through them. Our ambition was to use scoring, and scoring is you score different parts of the assessment, and it all accumulates. And I'll illustrate this through an example. But scoring, the reason why we brought in scoring is then it's more open and transparent to the provider of where they've scored really well, where they haven't scored that well, so that they can focus on those areas that it's clear. This is where you had low scores, this is where you had high scores. So scoring was brought in because we felt it gives a level of transparency of how we give you the overall rating. And then the whole point was our reports needed, again going back to people and communities, our reports needed to be more succinct, a bit more reflective of the context. And one of the things I've been working on for the last 2 or 3 years is very much, let's say, GPs from ethnic minorities. If you're working in a deprived area, you've got your own challenges there, and our inspectors would go in and they'd look at the evidence, and then they'd write a report, and the practice would feel a bit hard done by. The facts were there, the evidence, the facts were there, but what practices wanted was some kind of narration, giving more context behind the findings. Okay, so if you're not hitting your screening targets or vaccination targets, it's all well saying, you know, practice requires improvement, it's got a value of, I don't know, 75%. But the report lacked the context, because then if you put the context in, if you're working in an area of deprivation, or you're working in an area where there are certain ethnic minorities which have certain cultural beliefs, which historically don't like vaccination or for whatever reason, it just felt that the report, something was missing. We were just looking at the facts, but we weren't giving any context. And anybody reading that report would feel a bit aggrieved, to be honest. And I know these reports are public and patients can read them, but let's be honest, I don't know how many patients would read reports. Maybe some do, but really, when you've had an inspection, the first people that read the report will be the provider. So part of our ambition is to look at our reporting structure and improve that, and that's still ongoing. Okay, right, so let me just walk you through our single assessment framework. Many of you will know it. No doubt you've probably heard this before many a times, but I'll refresh. So the 5 key questions stay the same: caring, responsive, well-led. They stay the same, nothing changes there, but it's the way we collect information and the way we illustrate whether you are hitting the standards is different, and the way we do it is through quality statements. And the quality statements are actually based on a narration which actually resonates to a patient. So for example, I'm making one up. As a patient, I want to make sure that when I transfer from one service to another service of the NHS, you know, my information flows and seamless care, etc. And the thing about quality statements are they actually make sense, and then when you look at that, you can say, yeah, we've got evidence that that is happening. So it does give you a bit more framework of how you can evidence towards the quality statements, and I'll give you an example in a second. So here are some quality statements. Remember, the 5 key lines of inquiry are the same: safe, effective, caring, responsive, well-led. So under each key line of inquiry, so for example, safe, we have a number of quality statements. I think, correct me, Leanne, I think about 36 altogether across the single assessment framework. Yeah. There is some slight overlap, but so under safe, we'll look at the learning culture, we'll look at the environment, safe and effective staffing, medicines optimisation. That's got a Z on there, obviously. Spell check was on USA board, not English. And the effective caring. And these quality statements are on our website, and let me just show you a few more. Well-led, freedom to speak up, partnerships and communities, listening and involving people for responsive, equity and access, etc. So under each quality statement, there are a number of evidence categories. Okay, so evidence can be sought from various sources. So the thinking behind this was we wanted to give providers a framework. So here's a quality statement for you to collect evidence against. But to help you, you could actually collect evidence through a number of categories. So it's a bit like a filing system. That evidence is people response. That evidence is systems and processes. This evidence is from staff, etc., etc. So I kind of like the idea of giving you a bit of a framework. Remember, you're not collecting anything new. You're just collecting what you've already are used to collecting, but now you're kind of putting it into kind of different categories, or our inspectors are putting it into different categories really to see if you're delivering the quality statement. And then underneath each evidence, there's often we have to compare with evidence guidelines, etc., etc. So if you're looking at prescribing, we might do clinical searches. The guidelines which underpin our clinical searches are MHRA, NICE guidance, etc., etc. So there is always a rationale underneath the evidence categories as well, in some cases. So this slide illustrates, hopefully puts the whole picture together. It's not a great example, I need to change it, but nevertheless, for illustrative purposes. So, quality statement, this is about safe systems. And this is about safe systems, pathways and transitions, and as you can read, it's all about working with people and partners. Carrying on, obviously I haven't got any slides, but nevertheless I can kind of explain it. So you've got quality statements. So 5 key lines of inquiry. Let's take SAFE as a key line of inquiry. Under the key line of inquiry, you've got a number of quality statements which, if you can provide evidence against, clearly you demonstrate that you're safe. Under each quality statement, okay, you can submit evidence, and at this moment in time, we categorise evidence in more or less 6 categories. Not all categories apply, depending on the quality statement, but for example, feedback from patients, feedback from staff, feedback from other organisations. Systems and processes, so this is what policy you've got. I'm challenging my brain now, I should know this off the top of my head. Can you understand why I use slides? So the reality is you've got feedback from patients, you've got feedback from other organisations, you've got systems and processes, and for, let's say, GP, we also look at evidence from clinical records because we do clinical searches, as you know. So clinical searches are done by GP specialist advisors, they're GPs by background, they dive into your system and they do a search. Okay, and I don't know whether people at the back are going to see that screen, but nevertheless. I think that might be the plan, but let's see if we can get through the presentation. So the evidence categories will vary depending on the quality statement, and they're really there such that you can say, well, this is patient feedback, put it into that evidence category. These are our policies, put it into that evidence category. Infection prevention and control. So really nothing rocket science, it's just a bit of a framework happening. Okay. Sorry. Yeah, do you want to?
Yeah. So, sorry, I was just going to give you an example. So we're now able to, when we look at the key question responsive, if we're looking at, let's say, for example, equity of access, it now enables us to look at GP patient survey results, which is the feedback from patients, but then we can also speak to staff and leaders and look at the processes that you have in place to kind of address any lower than average performance. And we can take that into consideration, and each element will be scored according to the information that you provide to us. So it makes it a little bit more equitable how we score you. That's just another example.
Thanks, Leanne. I'm going to just skip through some slides. I don't know whether the screen's working or not. Is there something happening on the screen? Yeah. Excellent. You probably can't read it now at the back. Really?
Yeah.
Okay. That's not too bad. I'll create a presentation. Right. Plan B has come into action. Thank you very much. Thank you very much. So, what you can see there is you've got an example under SAFE. The quality statement here is about safe systems and pathways. It's about we're working with people and our partners to establish and maintain safe systems of care in which safety is managed, monitored and assured. Okay, so what we've decided is that we're going to look at 4 evidence categories to see if you're delivering that quality statement. They could be about processes, they could be feedback from partners, feedback from staff and leaders, and people's experience. So for general practice, people's experience could come from PPG notes, obviously the GP National Patient Survey. In terms of feedback, when we're out on site, we'll speak to your staff, so it's what they tell us. We'll also speak to commissioners, for example, what they know about your practice. So you get the gist. There are a number of evidence categories. It just gives you a bit of a framework to demonstrate that you're actually delivering to that standard. So when we get the evidence category, we score the evidence categories, and the scoring is between 1 and 4. 4 is exceptional, 1 is you've not met it. And we do apply some limitations to some of the statements, but the key thing is that we look at all those scores and we basically total them up, and we get an overall score which we then can correspond to an overall rating. So here you can see this quality statement is about involving people to manage risk. The categories that we're looking at are people to experience feedback from staff, processes, and here we found, when we looked at the evidence, we scored 3 for the practice for people's experience, we scored 3 for feedback from staff and leaders, and 2 for processes. That gives a total of 8 out of a possible 12. That's 66%, which then gives a rating, gives it a 3 for that quality statement. And we do that for all the quality statements that we're looking at. And here you've got an example where we've looked at all these quality statements under one key line of inquiry, and those scores basically is 22 out of 32, which gives 69%. And 69% falls into the good category. So for that key line of inquiry, safe, you're good if you've scored 69%. Now if you notice there's also a range. So you could be good by scoring 63%. You could be good by scoring 87%. And often practices, when they look at their neighbours in particularly, or practices which actually look at other practices in the area, they say, well, we're good, they're good, and we know we're better than that practice. How can that be? At least under the scoring, there is some differentiation as such. But ultimately, you can see you could be one off outstanding, can't you, and still be good, or you could be one off the bottom and you could be just good, just outside required improvement. And the advantage of scoring is that under each line of inquiry, you can actually focus on the scores. When you're doing 3s and 4s, marvellous. Where you've got 1s and 2s, you really need to look at that and see, was there evidence that actually you did submit? Was it taken into account? Or actually that's an area where you need to put planning and look at improving that scoring. And under the single assessment framework, the other advantage is that, let's say you're doing some work in a particular area, we can actually then come and look at that particular area, and that can change your whole ratings just by changing scores. So that's how it is supposed to work in theory. Right, okay, we're nearly to question time. Okay, nearly to question time. Just wanted to, one of the questions I guess most GP practices ask is what are our plans regarding priorities of this coming year? Now, naturally, they fall into 2 categories. One is responsive. So as a regulator, anything coming through our door, whether it's a complaint, whether it's whistleblowing, whether it's information that we receive from the ICB, NHS England, wherever, we've got to act on that, and we will respond accordingly. Okay, and just to give you an idea, it's not, we don't deal with individual patient complaints. I think everybody knows that, because as a regulator, individual patient complaints need to be dealt by the service provider in the first instance, and there are mechanisms to expedite that. But patients still complain to us. Patients still complain to us, and we write them a good letter saying these are your options. Please, you may wish to speak to your practice and put it back. So we're not there to investigate individual complaints. But as a regulator, if we're getting lots of complaints about a particular issue around a particular practice, it starts forming a picture. And when that happens, and it might not be a patient complaint, it could be concerns from other partners, it could be a whistleblower. As a regulator, we've got a duty, a statutory duty to act. So what we then do is we use that information, it gets flagged, and there's a team meeting. And Leanne, is it called DRM now?
Decision review.
Decision review meetings now. They used to be called management review, but now we've changed it to decision review meetings. And in that decision review meeting, there are people like Leanne, who are obviously inspectors who are saying this is the evidence that is coming into our intelligence. We also have legal representative. We've often maybe have a GP specialist there, especially if it's complicated, and other members of the team, somebody like an operational manager, which is a senior inspector, and they actually discuss that evidence that's come in. And in an MDT format, okay, a decision then is taken. And remember, as a regulator, our decisions have to be proportionate and necessary. So not everything that we discuss at our decision review meeting will result in an inspection. There could be a wide range of actions that we might decide. A bit like clinicians, when you see certain symptoms, you still have the opportunity to go down a certain route, but you might say, well, actually, let's wait and see. Might get better on its own, etc., etc. So there's a wide range of decisions that can be made from, actually, no, that's absolutely fine, there's no action, to let's wait and see if we get more information along these lines, to actually, let's contact the practice, speak to the practice manager, give them an opportunity to explain, to, okay, we need to do an inspection. And that inspection could be, we'll give them a call, try and arrange an inspection, usually around 2 weeks' time. Or, in rare occasions, but we still have the statutory power to do it, we might say, right, okay, we're going to make it an unannounced visit, in which case it is unannounced and we turn up and we say we're going to do an inspection today, as such. So, by the way, working in general practice, I've been subjected to CQC visits in my kind of career, and I know for a fact that it doesn't matter if you get a phone call and say, can we come in 2 weeks' time, or whether it's unannounced, it's still, you've got the regulator coming to look at what you're doing. Human nature says it makes you anxious, it makes you stressed, and I can only apologise, but it's a human reaction. Whenever somebody wants to look at what you're doing, then, unfortunately, it can induce stress. And of course, we've got inspectors like Leanne who try to support the practice and try to, support them in a positive way. But we do recognise we're human as much as everybody here, that, getting a CQC telephone call, a letter, email is never a pleasant experience as such. So I do recognise that because I've been on the other end. So the planned inspections, and I'm going to hand it over to Leanne just to talk a bit more about kind of our priorities. The planned inspections really are very much silent services. We've not seen you, heard anything about you for a number of years, so we think, why not pay you a visit and see how you're doing. Okay, mind you, we've got 6,300 and some registered practices, so you can imagine there are quite a lot of practices which we haven't seen for a long time. That doesn't mean we don't get intelligence on you, because remember, as a regulator, we can look at prescribing patterns, we can look at vaccination rates, we can look at your GP survey. There's a lot of intelligence that we can look at on an ongoing basis, and what you do get is a kind of an email, I believe, which says, nothing to worry about this month. Sorry, is it?
Every month about Atlantis, is this the one? Oh, no.
Right, okay.
Just so you know.
Okay, well, I've got to apologise in advance because as I said, I've been upfront in saying that any communication from a regulator is never, it's going to make you anxious, and I apologise for that. But so we do look for it. We look at information, and information comes through all the time. That doesn't mean that we're going to knock on your door and say we need to do a full inspection. But as you can understand, as a regulator, we have a statutory duty. If there's anything of concern, we might make a decision to come and inspect. And whatever decision that we make has to be proportionate and necessary. So it's not arbitrary decisions. There is a whole decision tree that we have to follow. We've got lawyers who challenge inspectors and saying, where's the evidence for that? If you're saying this, but where's the evidence? So there is a lot of internal challenge and scrutiny before the decision is made. So I'm saying this because practices might actually think, well, it's it's the inspector. Now Leanne might be okay, but you know, if I get another inspector, they don't like us for whatever reason, and they're going to come and start looking at everything. It doesn't work like that. It's an MDT approach, and there are people out there, and especially in complicated cases, we usually have a GP specialist advisor. I've got a number of national advisors who are GPs, jobbing GPs, who actually give a kind of a clinical perspective as well. So decisions are never made lightly, they're always made in an MDT approach, and we follow the evidence, and whatever we do has to be necessary and proportionate. And I need to say that to just highlight the point. I'm just looking at the time. New ways of organising, I think I've mentioned that. Team structure, yes, we've all come together now, so Leanne is part of the team with other inspectors and assessors, and we've also brought in different roles like coordinators who do a bit of back office function, etc. So we are trying to be more efficient. So Leanne, before the transformation, Leanne would have been part of the PMS team. So myself, as a Deputy Chief Inspector covering the South, I would have been responsible for all the operations there as well. As well as setting the strategy, also the operations. Now, very much so, as the Director of Primary and Community Care, I set the priorities at national level, and then they actually go down to network directors who have deputy directors and then operational managers, and they actually use their teams according to resource to deliver those priorities. So very much, I'm no longer involved in operations, okay? You might be lucky enough for me to join an inspection team to shadow, okay? But that's mostly of my interest to come out and see you and see the team really as such. So I'm no longer involved in operations, albeit the national strategy I do help to set. So that's enough of the presentations and the IT glitch. Thank you very much for the second screen. I'm now going to I'm going to give the mic to Leanne, just to talk a bit more about some inspections, and then if it's okay, we can answer any questions that you may have. Thank you.
So we're still very much in the early stages of the new assessments, and actually getting out there and doing it, but my initial experiences have been quite positive. I've carried out 2 assessments, both outside of Leeds, but one was a risk assessment because we'd received quite a high volume of complaints coming through from patients regarding access, which is generally one of the main themes that we get through, unsurprisingly. So we'd had about between 39 and 50 complaints come through, which obviously started ringing alarm bells. What I liked about the new system, the new methodology, is that we were able to look, like the example I gave earlier, we were able to look at patient experience, but we're also able to look at there were brilliant steps the practice were taking to try and kind of work with patients to improve satisfaction. And I think a lot of it was more around patient understanding of the new appointment system rather than there being an issue accessing an appointment. I've just also completed or finished gathering the evidence for a comprehensive, or what would have been an old-style comprehensive for a practice that was in special measures. So I'm in the process now of reviewing all that information and looking at it from the different quality statements and evidence categories. In terms of priorities at the moment and where we're focusing, we're looking at getting back out to everybody that's not rated good, basically, and re-inspecting those practices. And I know going forward, we're looking at getting back to those practices with an aged rating of kind of 5 years or more. So I'm not sure when those actual locations are coming down to the hub to be assigned to us, but I'm hoping that's going to be sometime soon.
Thank you very much, Leanne. So the message, I guess, is if you've not had a visit from the CQC for a number of years, then you might be in the bag where we pull out your name so we come and visit and say hello. But like anything, you know, we've got a lot of registered providers, and we've always got to balance what's coming through our door in terms of concerns versus us also, going to visiting practices which we haven't visited for a while. Just also to give you a heads up, is there anybody here who got contacted just after Christmas or during Christmas in the first, in the kind of winter period, where our inspectors contacted you to have a quick chat about access? Okay, so we did approximately 300 of those calls to just understand what was happening in terms of access, and I'm waiting for all those findings to be kind of presented and analysed as such. But just to share with you what's on my mind really, access is always going to be hot potato politically, patient-wise, and what have you. So once the team has analysed the GP access assessments, they're going to make some recommendations, and the chances are, going towards autumn and what have you, we might do some more work around access. What I'm also excited about is the report, the GP national survey that comes out from NHS England. Usually it comes out about this time. It's not out yet, is it? I don't think. But that would be very much interesting to see how things have changed as well. Okay, so access is always one of the things I'm worried about. So, questions?
Can I ask you about where you get your reference points for that from? So, I'm GP, and I may or may not need a microphone, quite loud, but Dave Kendall, a GP from Otley, which is a semi-rural part of town way out in the sticks. Access is a very interesting problem, isn't it? Because I'm going to be a bit political, but general practice has been defunded for 15 to 20 years, whilst our demands have gone up significantly. Just in the last year, with inflation, our funding has gone down by 10%, and yet access requirements since COVID have gone up by 30 to 40%, plus the complexity. And these are not me making these numbers up, we've got the data to prove it. And yet, we're being assessed on a standard which is, with the greatest respect, looked at from a distance, not necessarily in the context of that. And one of the reasons we have the access problem is because the rest of the system isn't functioning. I know you've referenced that, but that's a massive issue. And there are nowhere else for people to go. So me hearing about access is a case of you guys should be like, if they're seeing anybody doing well, to be really honest, in whatever form they need to do with apparatus, because that's obviously what they need to do. So my question, that's more of a statement, my question is, what reference do you take from the GPC or from reliable industry bodies that are on this side of things to help guide where that sits? Because it needs to be in the context of the possible, not the desirable, because we all want to see somebody tomorrow, but what's possible?
Okay, that's a really good question. It wouldn't surprise you that on a monthly basis I speak to GPC colleagues, Julius, on a monthly basis I speak to a lot of GPs as well to talk about current issues, and access has been a long-standing issue. Completely agree with you. The key thing for me is, let's say the GP survey, that's one point of reference, isn't it? And I know the limitations. Every piece of information has limitations. You're looking at information from January to April, I assume, or thereabouts, and it comes out once a year. So if I'm looking at your data, it's October. How do I know that what I'm seeing from January to April is still relevant? But nevertheless, it's still data, okay? And I would expect my inspectors to be aware that that data is, 6 months plus out of date. But nevertheless, it's a starting point to say, your patients, okay, this is what they're saying about your practice, okay. So it is about inquiry. It is about inquiry. This is what your patients are saying. Obviously, as a practice. As a CQC, we don't really get involved in the commissioning decisions. I used to, when I used to work.
I appreciate that, but that's the world you live in. So
yeah, I do. But we all have different remits, and so the message I can say to my inspectors and what have you is, you know, when you're writing a report, okay, and remember those interviews that you're having with the practice manager, staff and what have you, weaving some of that context, okay? Because when somebody's reading it, the facts are the facts, but the context actually gives you a backbone to look at those facts. The reality is, I think the last figures, going back last year, I think it was just 51% nationally were not, they didn't feel it was good access. You know, I don't know what the results will be this year. One thing that I'm very much interested in to develop really is at this moment in time, the way that we're set up is we look at individual providers and we talk about them. So what we say is, we looked at this GP practice, this is their access, this is what they've said, these are our findings. Okay. I would love to move towards a future by which we take ICS data, okay, or even data which compares your cluster of practices to another similar cluster of practices. It could be elsewhere in the country, in a similar situation. So we're comparing how you are with your peers, if that makes sense. But that again gives a different perspective, okay? So I'd like to move towards an area by which we look at things through various lenses, because that gives you more contextual, that gives you more context around what is actually happening in the practice. Remember what I said initially? Everything that's happening in the system will have an impact on primary care.
Yes, you did. And I want to pick you on that, and I will be quiet in a second.
Okay.
Because you're inspecting me, you're not inspecting the system. On that day,
Yeah.
your decision on that thing will say need improvement through factors out of my control.
Yeah.
That's the issue I have with the inspection process. There are lots of things. You mentioned vaccinations. I imagine that practice was told they were in need of improvement when you'd already identified there was nothing they could do to improve that vaccination uptake because of cultural reasons. That's the issue I have. It is not been seen in the context of the system we work in. It is Dave's practice, John's practice, Jenny's practice, and it's not seen, historically, and maybe you've changed, but not you, but the system is not seeing the totality. They're just looking at that particular practice and can do lots of good, but the pressure and the problems it causes, you guys walk away, it's left then for that practice to then deal with the implications of a team who are already on their knees, dealing with something on a, could I say, technicality sometimes, which is outside their control largely. And that's the issue I have with the system.
Thank you.
So
I think that goes back to what I said earlier. And I think historically there has been, for example, when under the old methodology, we'd come out and look at responsive, and a lot of that was focused on those, you know, your patient survey results, which I totally get where you're coming from and the issues you have around that. I think as an assessor now, looking at that information, I think I'm very mindful, and I always have been, that GP patient survey results represent a very small number of your practice population, and responsive as a key question is a lot bigger than access. I'd love to say that every practice, you know, satisfied all the patients, but I think the way things are going, patient expectations are going up and demand on practices is increasing. I think what I'm looking for as an assessor when I go out is that you've got systems in place where you can prioritise those patients that need an appointment and, you know, that need to be seen urgently, and you have systems and processes for patients to be able to book an appointment, not necessarily the same day, but that there's a process in place to support patients and it's accessible to all.
Thank you. I mean, you always have been very supportive. This is not about individuals, it's just about the process.
Yeah.
I'm sorry.
I'm just going to say, it's a far from perfect system, but there are things that we can do to improve it, and I guess if we can work on the context, once we've got ICS data, okay, if we can bring that context in, then suddenly you get you are getting a system picture, and then your part, the part that you play as part of that system. We're not there yet. Thank you.
Thank you. Got a question for Lucy.
Hi, I'm Lucy, one of the LMC officers. It's another access point, but different. And what I think was really interesting about your example there, Leanne, was the complaints were about access, but after your investigation, you realised it was more about patients feeling a bit unsettled about a change in the appointment system. When we went to the national conference recently, there's been a really interesting piece of research done by one of our LMCs that have used the patient satisfaction survey data and looked at what that actually truly correlates with. And what they found was patient satisfaction correlates well with a patient's experience of booking an appointment, not access and the ability to book an appointment when they want it. It correlates with them having access to pleasant reception staff who can talk to them nicely. It correlates with them feeling listened to in their consultation. What they found it doesn't correlate with at all is the number of appointments that GP practice is offering. And in fact, interestingly and potentially concerningly more, you have practices that are not offering very many appointments but are managing to have a very satisfied patient population, and you have practices trying desperately to meet this access message and very, very poorly satisfied patients, and those are the ones at risk of having to hand back their contracts or have CQC issues because they are then not managing to be a quality service because they're trying so hard to achieve access. So I just wonder, well, first of all, we could forward you that information. If you're not aware of that research, it would be interesting to have your take on it. And, how can you help change the narrative and help GP practices actually genuinely help satisfy their patients more in a more constructive way?
Thank you for that. I guess the first element of that is the number of appointments offered by a practice is more contractual rather than regulation. So it's not something that we get, involved in detail. However, what we respond to is noise from patients and kind of if we think there's an issue. So we look at the systems and processes, and I mean, I agree. I think it's something we could look at, more routinely, look at the number of appointments per 1,000 registered patients. But I think we couldn't, the breach of regulation wouldn't come from the number of appointments offered. That would be more contractual for the ICB to pick up.
Maybe I didn't make it clear. I'm more suggesting the opposite, that you don't focus on the number of appointments, you focus on why patients might not be satisfied and helping GPs realise that the road to patient satisfaction is not actually in creating more appointments, it's making the patient experience better.
Right, okay.
Okay. So, on the NHS England website, and they produce it every month, it's been a while since I've last looked at it, but I speak to my NHS England colleagues on a regular basis. When it was the number of appointments, there are more appointments now than ever before, okay? So you're absolutely right in that kind of link about, well, if we're offering more appointments and satisfaction is going down, then clearly it's not as linear relationship as you would expect. And it all goes back down to demand, of course, and expectations. So I understand that, and that's why the responsive element of our assessment isn't just focused on, how many appointments you give, because that's not an issue. What we're looking at is how you respond to clinical need, and obviously what is appropriate for a single mum who's got a crying baby might not be appropriate for otherwise healthy adult male, So when it comes down to clinical appropriateness, that's really up to the practice to manage. So it's not, we can't go down to the basic level of, oh well, you're offering X number of appointments per GP, X, Y, and Z, because that really, it might be factual, but it doesn't give us a complete picture. So that's why when we look at responsive, we look at everything else as well, okay, and put it into context. The point I was making earlier is that actually it would be really useful when it comes down to just say access, to look at how the system's coping. Do the hospitals have very, very long waiting lists, all sorts of issues, And then what we can do at a system level, okay, is when we assess the system, we can, my approach would be, okay, ask the system, you've got a group of practices working in the deprived area, for example, who are really struggling. Okay, what is the system doing to support them? Okay, and that's my kind of approach. We still, as a registered provider, still have to go in and look at what you're doing, but I'd like to be in a place where we actually look at that in the context of the system, and then actually challenge the system to say, people are struggling here, patients are experiencing this, okay, what are you as a system doing to help that group of practices to come out of it? And that's where I think, now, over this year, we might, I think we've got colleagues on ICB, but one of my ambitions this year, as you can imagine, I do get out and about, is to speak to directors of primary care at ICB level. And the questions I'm kind of asking is very much, you know what's happening on your patch, you've got the data and what have you. My questions are, how are you reducing inequalities? And more importantly, when you've got areas of inequality, okay, how are you working at a system level to address that? Okay, so that's my approach. At a national level, when I'm speaking to colleagues at NHS England and others, I don't get into contractual issues, but I do say, very much so,
data and looked at what that actually truly correlates with. And what they found was patient satisfaction correlates well with a patient's experience of booking an appointment, not access and the ability to book an appointment when they want it. It correlates with them having access to pleasant reception staff who can talk to them nicely. It correlates with them feeling listened to in their consultation. What they found it doesn't correlate with at all is the number of appointments that GP practice is offering. And in fact, interestingly and potentially concerningly more, you have practices that are not offering very many appointments but are managing to have a very satisfied patient population. And you have practices trying desperately to meet this access message and very, very poorly satisfied patients, and those are the ones at risk of having to hand back their contracts or have CQC issues because they are then not managing to be a quality service because they're trying so hard to achieve access. So I just wonder, well, first of all, we could forward you that information. If you're not aware of that research, it would be interesting to have your take on it. And, how can you help change the narrative and help GP practices actually genuinely help satisfy their patients more in a more constructive way?
Thank you for that. I guess the first element of that is the number of appointments offered by a practice is more contractual rather than regulation. So it's not something that we get, involved in detail. However, what we respond to is noise from patients and kind of if we think there's an issue. So we look at the systems and processes, and I mean, I agree. I think it's something we could look at, more routinely, look at the number of appointments per 1,000 registered patients. But I think we could, the breach of regulation wouldn't come from the number of appointments offered. That would be more contractual for the ICB to pick up.
Maybe I didn't make it clear. I'm more suggesting the opposite, that you don't focus on the number of appointments, you focus on why patients might not be satisfied and helping GPs realise that the road to patient satisfaction is not actually in creating more appointments, it's making the patient experience better.
Right, okay.
Okay. So, on the NHS England website, and they produce it every month, it's been a while since I've last looked at it, but I speak to my NHS England colleagues on a regular basis. When it was the number of appointments, there are more appointments now than ever before, okay? So you're absolutely right in that kind of link about, well, if we're offering more appointments and satisfaction is going down, then clearly it's not as linear relationship as you would expect. And it all goes back down to demand, of course, and expectations. I understand that, and that's why the responsive element of our assessment isn't just focused on, you know, how many points you give, because that's not an issue. What we're looking at is how you respond to clinical need, and obviously what is appropriate for a single mum who's got a crying baby might not be appropriate for otherwise healthy adult male, you know. So when it comes down to clinical appropriateness, that's really up to the practice to manage. So it's not, we can't go down to the basic level of, oh well, you're offering X number of appointments per GP, X, Y, and Z, because that really, it might be factual, but it doesn't give us a complete picture. So that's why when we look at responsive, we look at everything else as well, okay, and put it into context. The point I was making earlier is that actually it would be really useful when it comes down to just say access, to look at how the system's coping. Do the hospitals have very, very long waiting lists, all sorts of issues, you know, and then what we can do at a system level, okay, is when we assess the system, we can, my approach would be, okay, ask the system, you've got a group of practices working in the deprived area, for example, who are really struggling, okay, what is the system doing to support them, okay, and that's my kind of approach. We still, as a registered provider, still have to go in and look at what you're doing, but I'd like to be in a place where we actually look at that in the context of the system, and then actually challenge the system to say, people are struggling here, patients are experiencing this, okay, what are you as a to come out of it? And that's where I think, now, over this year, we might, I think we've got colleagues from ICB, but one of my ambitions this year, as you can imagine, I do get out and about, is to speak to directors of primary care at ICB level. And the questions I'm kind of asking is very much, you know, what's happening on your patch, you've got the data and what have you. My questions are, how are you reducing inequalities? And more importantly, when you've got areas of inequality, okay, how are you working at a system level to address that? Okay, so that's my approach. At a national level, when I'm speaking to colleagues at NHS England and others, I don't get into contractual issues, you know, but I do say, very much so, you know, how can NHS England, and answer those questions, how are you supporting patients so that they get access, go to the right person at the right time, and it's not all about just bringing in GP surgery, you know. So there are things that we can influence, and it's not as straightforward as number of appointments, because we know number of appointments now is far more than what they were ever before. Thank you.
Thank you guys, sorry I'm up on a lot of feedback, it's probably easy without. I'm a GP in Bradley, and I've just got to echo, you were really helpful when you came and did our last, I think, was it 2018?
Thank you.
Well, no, I think if it wasn't, it was the first thing you said, I remember, you walked in the room with, we're not here to judge your access. And I think that did actually set the scene for that day, which was really good. It was just to sort of follow what a few things. I know what I see in my room, what we see in the practice, but is anyone actually looking at how much GP time is being taken up by secondary care, work dumps and bouncing, and how many patients we're seeing, and when's my next appointment, what am I doing this, when am I doing this, because it is so much, I don't know, is anyone actually looking at it higher up as to how much time is being wasted in general practice on that?
I can't give a yes or no answer to that, but at the CQC, okay, at the CQC we've got people looking at urgent emergency care, okay. I'm not sure whether it's mine or the chair's. So I've got colleagues in secondary care, I've got colleagues who are looking at urgent emergency care and what have you, and it's a well-known recognition that one of the factors which, and I've experienced it before, remember our urgent sessions in practice, that one of the factors during COVID is because there are long waiting times in secondary care, people aren't getting their treatment, okay, and they're getting worse, then primary care is picking up things which really they shouldn't pick up because they should have been picked up in secondary care. So we recognise that, We recognise that. And, you know, the conversations I've had with NHS England, of course, they recognise that as well, because ultimately everything's interlinked. Everything is interlinked. And primary care is in that unique position, because somebody can ring up your surgery and ask to see somebody. You can't do that to a hospital, can you? I mean, the only thing you can do is turn up at A&E, okay, which we're not encouraging people. But so we are completely aware of that. And one of the things I'm very much interested in, again, Claire Fuller wrote a report a few years ago, you know, the Claire Fuller stock take, talking about integration, talking about investment, and what have you. I speak to Claire on a regular basis, and what have you. One of my questions when I go out to ICBs is, okay, there's some ambition there. What's happening to make that ambition to fruition? A lot of work needs to be done. So we do try to influence other organisations, but you know, we know it's not a perfect world.
Any more questions?
I'm happy to shout.
Do you mind if you just, because we're recording?
Yeah,
Is that
of
okay?
course,
So
yeah.
everyone can hear. Thank you. Thanks.
I was just asking about what it's actually going to look like with the new model when someone comes to visit. Will it be like an old comprehensive assessment where we're going to be assessed across all 36 areas in one go? Or is it, as you're suggesting, going to be more of a rolling thing where when you come into a practice you might just be looking at one or two of the areas, or is it going to be different from before?
In terms of announcing inspections and all that kind of thing, you'll still get the 2 weeks notice as minimum in order for us to send the PIR request out and for you to have the appropriate time to collect that information and return it. Where we're responding to risk or we've identified risk, it will be a focused inspection, and we'll just look at, it might even be just a couple of quality statements out of an evidence category. Where it's a comprehensive, we'll be looking at everything, unfortunately, so it will be the full shebang. We'll still do a lot of it remotely, so we'll be sending out, we'll do remote interviews unless you want us to do them on site. We'll arrange interviews with practice manager remotely. We'll send out questionnaires to his staff so that we can get a wide range of responses. And then the site visit will still be the shortest site visit in most cases, unless there's something in particular that we need to be on site longer for. And the GP searches will be remote still, with the remote GP interview.
More questions?
Thanks, Ian.
Oh, hi. Jan O'Mahony, I'm from the ICB. I think it might be unfortunate that I'm the only person, so don't shoot the messenger. Just the first point about the interface. Work is going on. I'm not directly involved with it, but I know the LMC and the ICB are working very hard with colleagues in the system to address that. Now, I'm not suggesting for any minute that that's, you know, I think one or two areas may be starting to impact, but they're probably very small. But we are well aware of the problem, and people are working on it, and you know, if people want to get involved, then I think in the first instance contact the LMC, because it really is a very difficult issue, and it is having a major impact on primary care. My second point was around what you said at the beginning, Annie, about looking at health inequalities and practices in deprived areas. You know, I'm glad to hear that you look at the context of, you know, where people are now working. I used to work for CQC, and I did some quality assurance work, and you know, I used to fight on my own in meetings to say, you know, this practice is working really hard to address those. They're working 3 times as hard as a practice in a slightly less deprived area. That's not to say the other practice isn't working hard, but sometimes it can be really difficult. And those, all immunisations have got much more of a challenge since COVID, and we all know that. But when you say you look at the context, and that's part of the narrative, what I'd like to know is, does that affect the score ultimately? Because if it doesn't, It's just words that provide some, you know, some context. But if it doesn't change anything, then we're still in the same position where practices who are struggling, doing their very best, come out with an RI, and it's so demotivating. We have to go in and follow that up, and you know, having difficult conversations along those lines is not easy. So, is it possible to comment on that, please?
Yeah, of course, I'm very happy to comment. The context doesn't necessarily change the scoring, okay? And I say the word necessary because there might be some exceptional circumstances where when people read the context and it's very borderline, the context might actually swing it, but that's a decision for the DRM, okay? So there are always exceptionalities as such, but especially if you're at the cusp, the context might actually help people to go one way or another. But the reality is generally the context is the context, and I know it's not what you want to hear, but this is the reality behind it. The context is the context in terms of why, the reasons behind your performance, okay? But your performance, where we've got actual figures, those are the actual figures, okay? Those figures don't change because we draw on vaccination rates, for example, we draw from NHS England or Public Health or what have you. Those figures will be stated because they are what they are. What we're trying to do, okay, what I'm trying to do is actually put a bit more context behind it. So, I guess as an inspector, if you're going in and you see that they've got miles away from the targets and what have you, but they've written out to patients, they've tried some innovative ways, they still failed it, but that information needs to be put in that report to say, these figures are what they are, however, the reality is, this is what the practice has done to achieve it. And so we've got to look at the evidence and we've got to put the context there.
But I'm very sorry, but that's statistically poor because you've already excluded, you're comparing 100% in one practice with 100% in the next practice. It's inaccurate if 15% of that population, whatever you do, will never ever pass that. So they've probably actually achieved more than the equivalent. It's fundamentally flawed. You know, if you sit an exam, if you sit an A-level,
Yeah.
okay, and you get 68% and you don't get the mark you need, your mitigating circumstance might mean that that is then bumped up. Or alternatively, they may have decided one of those questions was inaccurate across the whole country. They remove the question. Okay? They don't just say, I'm really sorry, Dave, you got 68% for no fault of your own because of these poor questions or a mitigating factor. It's adjusted, and this score, which carries you for life, or in this case, many years with a disillusioned staff, is not based on statistically relevant information. If all you're doing is taking a denominator and numerator at a gross level, I mean, it doesn't make sense. Jan's absolutely correct, it makes no sense. And so to hear that reinforces some of the feeling I think a lot of people share that the scoring system is fundamentally flawed because the way it approaches it is flawed. The context is the context, but to be honest, nobody cares about that. You've either passed your driving test or not. The fact that you could have done if you'd only done this, I think this is the real risk, and this is what people feel. And, you know, that's the emotion in the room, I would imagine, about that.
So I guess, again, from my point of view, and I acknowledge all the hard work that's gone on in Leeds, particularly in the more deprived areas that, you know, we've seen lots of innovative work going out and outreach work. So I think, first of all, we won't have the evidence table anymore. So, you know, that was kind of soul destroying for practices, I think, particularly where so much hard work had gone on, where it was highlighted in red and things on the evidence table. But with the separate sections under each quality statement, it gives us that opportunity to score the work that you're doing, so that outreach work, and reflects that in the scoring. So it gives us a lot, you know, more opportunity to really reflect that in the rating that scoring aggregates to. That would be my take on that one.
Thanks, Leanne. As Leanne's trying to explain, you might lose some points here, but because of what you've actually done or what your circumstances, you might get points elsewhere, because there is some overlap. the reality is we don't live in a perfect world, okay, and no methodology is going to be perfect. Every methodology is going to have limitations, and I'm sure everybody in this room, including myself, can look at a particular thing and say, well, actually, that's not ideal. But this is where we are at this moment in time. What I was trying to say is that my ambition is to get smarter. The key strategic aim was to be smarter regulation. Okay, part of that smart regulation is actually, yes, we do look at the registered provider because we have to rate the registered provider, but what other data can we actually start using? And it could be that what you've done or your circumstances might give you some points elsewhere, which might balance things out. So it's more complicated than what I can explain. It's actually a lot more complicated than I can explain because there are limiters and what have you. Regarding flawed methodology, any methodology is not going to be absolutely perfect. And just on your comment, context, I see where you're coming from. If it's not going to change the rating and you still put the RI or what have you, well, it defeats the object. But I've heard this from GPs to say, we know where we are, okay, but when we read that report, it was hard hitting. And a bit of context would have just kind of balanced the environment. So there are still GPs, albeit, I take your point, respect it, valid. There are also GPs who say, well, actually, if you put the context behind it, actually that would have just, anybody reading it would have, had a bit more explanation of why we're in this kind of situation. So that's what I'm going to say on that. That's more questions.
Yeah, can I just say, July Manson GP, in terms of the phrase requires improvement, all that people are going to read is requires improvement, and no matter what efforts they've put in and what the score is, if you look at a report and you see that it takes no account of all the work that has gone around to try and mitigate the circumstances to try and get that. So I think if scoring is not going to recognise that, then the phrase requires improvement is just even more damning, because it just gives the message to the staff that they're not doing enough, and they have that feeling, well, what more can we do? We're doing everything we possibly can, and this is just not taking any account of that. So I would ask that is looked at.
I agree with you. When you're already struggling providing services, nobody comes to work wanting to provide a whole service to anybody. I get that, and I completely agree with you. You're working flat out, staff are working flat out, doing absolutely the very best in the circumstances. We look at the inspection, and through our assessments we say we still need to improve. Of course it's going to be demoralising, demotivating and what have you. At this moment in time there's really no kind of easy fix as such. We start with context because our reports were very, very to the point, to the basic. We're out of context. We need to, at the CQC, people like myself and others need to think of how we kind of address not demotivating staff any further. And there isn't any quick solution, but that doesn't mean I can't go away and think about it, because I care. I work in general practice. I've got links with general practice going back 30 years. I know I've been at the other end of it, and it's not my intention to demotivate people who are doing the absolute very best. But I take that on board, and it's something that we need to look at and come up with a way which actually gives a true reflection of what quality services patients are getting in a way which actually then has a bit of a balance and what have you. As an independent regulator, we're not representing staff, we're not representing GPs or health professionals X, Y, Z. Ultimately, we are giving a view to patients and service users. But I do take on board what you're saying, and it's something that we need to work on. How we're going to crack it, I don't know.
Thanks, Manny. Can I just ask a question on that? Sorry.
I guess it is difficult because, if there's a breach of regulation, which is what we're inspecting against, unfortunately, it's a breach of regulation. So all we can do is describe what the practice is doing, but ultimately, if it's breach of regulation, so our hands are tied a little bit in terms of the ratings. So we've just got to be able to include what the practice are doing alongside any breaches of regulation or any areas requiring improvement, and try and feed that back during the feedback session.
Can I just quickly add to that?
Yeah.
Nobody wants to receive required improvement and what have you, but when you do receive required improvement and what have you, sometimes that acts as a catalyst to get support in, whether it's the LMC supporting you, your local ICP supporting you, or what have you. And where we often find is where practices, unfortunately, have breached regulations, it triggers quite a lot of support to the practices to get back on equal footing as such. So it can be demotivating, I gather that, but the reports sometimes can also act as a catalyst for your support structure around you to actually come and support you as well.
I'm glad to hear that you agree, Manny. I mean, I think words are really important, and if in your position of authority, if you agree that these words are perhaps not ideal, is there any way of that being rectified? Could it be not like the number system instead? And I mean, I'm just concerned about, everyone heard in the news about the head teacher that committed suicide after receiving the inadequate Ofsted inspection. We all know that the figures for doctor suicides and nurse suicides is off the scale compared to other professions, a lot of those GPs, and I think it's so important that we look at that quickly. I think a number ain't the colour, but I think words are so important, and it really does impact people's morale and mental health, and we're hemorrhaging staff, and we just need to do everything possible to stop that. So in your position of your authority, how can you change that, and how quickly?
I can't change it as a sole person. I can't change it as a sole person. That doesn't mean I'm not sympathetic, empathetic. It wouldn't surprise you. Various organisations after that tragic event contacted me and said the impact of regulation on staff. That's why I started my little chat. I'm apologising up front because I know it does. For us to change any of our methodology and what have you, let's say to take all those things into account and move to something else needs consultation, a degree of co-production and what have you. So it's not something in my power to go in and say ABC, but I certainly have challenged with the colleagues and the executive team to say, especially after that tragic event, what are we doing to make sure that we minimise something like that happening in general practice? And we have done. There's staff training after that event, about staff training, about recognising and supporting and what have you. All the kind of training and educational needs for staff to understand how to deal with those situations. If we find across somebody who's overly anxious and what have you, we might try to get them more support. So we can do the softer things. Regarding changing the methodology, that would require quite a consultation and what have you.
I don't mean the methodology,
Yeah.
I just mean the actual words. Like we've done this with the amber drugs in Leeds. We're doing it at the moment, changing, I'm involved in the group that are looking at it, changing from black registered drugs because it's seen as a negative.
Yeah.
Even to use the word black, so we've got rid of that, and that's been going forward. That's taken about a year, but that's happening. So I disagree.
I will certainly take.
If you could, we'd really appreciate it.
The reason I come out to these events is to hear things like this, and I can say. So when I sat with the executive team and have an opportunity, I can say, well, I was at Leeds. There is this issue.
That'd be great. Thanks, yeah.
Okay, I think that was it.
I was going to make the same point that Sarah makes
Yeah.
said it.
Around language, mentioned just to John before Sarah started to talk, my daughter's report came out today and she requires improvements in several areas, but they don't call it that. They call it consolidating. You know, it's different language, and you know, again, it's not about changing the methodology, it's about this message will go out to the public. I totally respect that your regulation role has to be absolutely what it needs to be, but in terms of the message that goes out to the public, the methodology can stay exactly the same. Sorry, you get my point anyway.
I get your point. Basically, you can say the same thing in a slightly different way, which might have a slightly less impact. I get that.
The ultimate irony is you've already said it, patients won't read the report, it's the staff that read it.
Yeah. But the patients will read
But,
the
but,
word, yeah.
but, yeah, but it's
Well,
the staff.
I'll give you my personal view on it. Okay, the current, not the current outputs and what have you, but I've read reports before in the old format, and to be honest, if I was a patient, could I really make head and tails that way? Taking into consideration the average reading age of this country. Okay, so I think there's a lesson for us, and it has been recognised for clarity of English and what have you. The point I'm making is you might have in your list size 15,000 patients and what have you. They might look at the headlines, but if they try to pick up a report and read it, does it really make sense to them? I think we've got to improve our reports, and that goes back to using language which is appropriate. It still gets the message across, but in a way which actually is more effective and less likely to.
We used to actually do complain and no complain, didn't we, many years ago, which...
I will. This kind of feedback is valuable for me because I work with the policy team. So the policy team are the people who take all this and help develop our policies of what language you use and whether it's required improvement or X, Y, and Z. And it's important feedback actually. From my perspective, I want to be in a position. Nobody wants the regulator to knock on your door, send you an email or monthly email or what have you. But I want, as a regulator, to move to a point where actually, some of these things we can iron out and get to a better place. It's not going to be easy, but we can strive towards it.
So patients may not read the whole report, but they'll read your treatment post when it says requires improvement or whatever it says, they'll see that.
Yeah.
It's not just the report.
Thank you. Any more questions? Aware of time, and it's very warm up the front. Okay, thank you.
So just a question with access and this agenda on access, which obviously isn't more political necessarily. I'm aware of patients' access demands obviously since the COVID has increased. But we sort of mentioned to ICD colleagues, etc., is access at the expense of quality? Now you're both mentioning quality statements and quality of this, and you're assessing more than access. So, if you put a healthcare assistant instead of a GP, you'll be picking that up. But that's a question, just in terms of the broader context. Is CQC too close to the government's agenda on access? Just a bit. And what about, for example, RCGP's first statement on continuity of care, which we know is hugely connected with outcomes in terms of mortality data and admission to hospital inappropriately. There's not any continuity of care measures in the national contract, etc. So just mention it because I'm not sure that we're there with the NHS England's wedded to the access agenda. It's only just been mentioned in our local Leeds quality extra bits, which we were adding in just in one statement. So I think that's where continuity of care does need to be, and I think that longer term is where the quality is going to be coming out rather than pure access. I don't, yeah, just continuity.
No, that's absolutely fine. And I'm also a firm believer in continuity of care, especially with certain groups, because there's good evidence continuity of care gives better outcomes for certain groups of people. So I'm an advocate because I follow the evidence. Okay. To answer your question, you said, is the CQC, was it close to the government? We're an arm's length body at the end of the day. They set the statutes, we follow, we are independent from the government. And the reality is, if I'm at a bus stop, I'm not at a bus stop, but I'm just giving you an example. If I meet somebody and I'm talking to somebody, and they say, "Oh, Manny, what do you do?" Okay, and I say, "I work for the CQC," and there's only two responses to that, and the first response is, "Who?" And then I usually come up with the case of, CQC regulator for health and social care, a bit like Ofsted. And they say, "Oh, Ofsted, yes, okay." As soon as they've got who the CQC is, or if they know the CQC, the first discussion they have with me is about getting through on the telephone line at 8 o'clock on a Monday morning or what have you. Okay? I don't need any government and what have you. Everybody I speak to, from a patient perspective, okay, it is close to the heart. Now I know from this, that some of the changes that general practice have been brought in has really helped the situation. Whether it's a telephone line where you get into the queue, but you press a number, you put the phone down, and then when you turn, it comes up. So what the lady was saying, it's the experience. It's the experience. I can only talk about the practice which I'm familiar with and what have you. Everybody who needs to be seen, according to their clinical needs, gets seen. Reality is, but there will be 100 people out there with minor things who might think they need to be seen by a GP today, when actually it might be more appropriate for self-care or what have you. My personal view, and I use the word personal, is I think a lot of ICSs, NHS England, other bodies, voluntary sector, whoever, radio stations, the Sentinel, the Evening Post, what have you, they have a role also to educate patients as well on the role of what general practice can do for them and the role that they can also do for themselves, whether it's one-on-one or what have you as well. So until we change perception, okay, there will always be an inappropriate volume of people wanting to access primary care, which actually doesn't need same urgent day care and what have you. So it is complicated, and when I do speak to my NHS England colleagues, and I have said this to them, I've said, okay, you've got your contract and you're going to provide this support and you're going to provide that support. And I know they also have certain projects which they're working with certain practices to help practice to get to a better place. My view is that's great, supporting general practice absolutely, but what are you also doing to educate the public? Okay, because they are the people who are coming to your door, and not everybody needs to come to your door. So it's a very complicated, wicked problem that we need to solve, and you just don't focus on one area, you have to focus on a lot of other areas. The other element that we mentioned is prevention. Everybody talks about prevention is better than cure, but how much are we investing in prevention? Okay, so we can't forget prevention as well. If we can do that then basically doesn't help us now, but might help us further down the line. So there is an element of dealing with the fire now, but my personal view is that you also have to have strategies such that fire will be dealt with, will burn out, but going forward you've got less chances of dealing with fires.
Thank you, Leanne. Do you have any further questions before we draw this to a conclusion? Yes, sorry.
Just final one from me. I just want to say, when we come out to inspect you, we don't want to find, we're not looking, we're not trying to trip you up. and we really want to work with you to make sure that we get a good outcome. Where there is room for improvement, we will look for mitigated circumstances, and we will try to include that in our reports and liaise with you as practice. And at the end of the day, we're all people, and we've all got one aim and one priority. And I just wanted to end with that, really. Thanks.
Thank you, Leanne. Really appreciate that. We do appreciate you at work. And thank you, Manny, for taking the time to come over to Leeds.
Thank you very much for inviting me. It's hot in this room, isn't it? Is it the outside temperature, or is it just what I'm feeling? But can I just say thank you very much. I do appreciate being invited to events like this. I do appreciate the questions, the genuine questions, because ultimately it keeps me in touch. And as you were rightly saying, you know, what can I do from what I hear to help change, you know, and I'll certainly play my part, because we're all on one team, and at the end of the day, all we're trying to do is best for our patients. So thank you very much.
Thank you.